Welcome to the 2020 Vermont Statewide EMS Protocol Update, Stroke Part 2. This training will cover new important changes to our statewide EMS protocols and how we care for stroke patients. Field Assessment Stroke Triage for Emergency Destination, also known as FAST-ED, is a new stroke severity score that EMS will now perform in addition to the well-known Cincinnati Stroke Scale. Calculation of a stroke severity score will help EMS to get the right patient to the right place at the right time, improving patient care and outcomes. In the following slides, we will discuss how you can teach an old dog new tricks, the 2020 Vermont EMS Stroke Protocol Update. When I was a kid, my grandfather had a stroke, the bad kind, the kind that leaves you paralyzed, unable to talk, eyes deviated to one side. Years later, I learned this was called a large vessel occlusion stroke. Back then, there was not much you could do for a stroke patient. They would get put in the hallway somewhere until somebody got to them. It felt pretty hopeless. It wasn't until 1996 that new clot-busting medication, TPA, came along. TPA could help treat patients with small strokes if given within the first 4.5 hours of onset of symptoms, but did not do much to dissolve the devastating large vessel occlusions. Mechanical endovascular thrombectomy was the next big advance in stroke care. A catheter is threaded into the brain to remove the culprit large vessel occlusion from one of the major arteries that supply blood to the brain and restore normal blood flow. Removal of clots in this way can be associated with dramatic reversal of stroke symptoms and provide vastly improved outcomes for patients. Endovascular thrombectomy has been found to work even better than TPA and lead to significantly better outcomes, especially for patients with large vessel occlusion strokes. Unlike TPA, which can be done at all Vermont emergency departments, endovascular thrombectomy can only be done at specialized thrombectomy-capable centers. Here is an actual clot pulled from a patient. Initially, it was thought that thrombectomy could only be performed up to 6 hours after onset of stroke symptoms. This is why we would call a stroke alert up to 6 hours since time last known well in older versions of this protocol. Then, in 2018, the New England Journal of Medicine published a landmark paper showing that LVO stroke patients treated with thrombectomy had significantly better outcomes even when treated up to 24 hours after stroke symptom onset. This has significantly changed our approach to the stroke patient and created a new emphasis for EMS to not only screen patients for possible stroke, but to identify those with more severe stroke symptoms, such as LVOs, so that they can be triaged to the most appropriate treatment facility that is capable of performing endovascular thrombectomy. Thrombectomy is not for the small strokes, but rather is reserved for the most devastating large vessel occlusion clots, such as those involving the middle cerebral, internal carotid, or basilar arteries. Patients that benefit most from thrombectomy are those with a mismatch between the clinical deficit and infarct volume. The key concept is that ischemic brain tissue that has not yet undergone infarction, also known as the penumbra, may be salvaged with reperfusion, leading to dramatic improvement in stroke symptoms. This picture shows the core infarct area surrounded by the area of threatened at-risk brain tissue, or the penumbra. If the clot is removed and the blood flow is restored to the penumbra, that brain tissue can go on to survive, and the stroke deficit can be significantly reversed. The key is the MRI perfusion-diffusion mismatch. The small red area on diffusion-weighted MRI shows the core infarct, while the much larger blue area on the perfusion MRI identifies area of critically hypoperfused at-risk brain tissue. The mismatch between volumes, shown in green, represents the tissue at risk of infarction and the target tissue for reperfusion treatment that can still be salvaged if the clot is removed. Here are some actual pictures of an occluded artery to the brain. This catheter angiogram shows a filling defect in the internal carotid artery. Notice that the blood flow stops abruptly at the site of occlusion. Now we see the same artery with normal filling of the anterior circulation after removal of the clot. Notice how much more of the brain tissue is now receiving blood. You can imagine how this would reverse or limit the severity of a stroke. These findings were so significant that the American Heart and American Stroke Association quickly came out with a recommendation to increase the treatment window for mechanical clot removal from 6 up to 24 hours in appropriately selected patients with large vessel occlusion clots. The expanded time window for mechanical thrombectomy will allow us to help more patients lower their risk of disability from stroke. That's a big deal. That's potentially a lot more people who could benefit from the procedure. For patients that need to be transferred from an outside hospital, it gives us more time to get the patient to a thrombectomy-capable center. The treatment window is 24 hours, but time is still a critical factor. The sooner thrombectomy is done, the more at-risk brain tissue can be saved. These new guidelines have completely changed the landscape of acute stroke treatment for EMS, making early recognition of large vessel occlusion stroke in the pre-hospital setting a new priority for EMS. The problem is that not all strokes are large vessel occlusions. In fact, only about 20% of pre-hospital stroke alerts will be LVOs. Current Vermont EMS protocol screens for the presence of a possible stroke, but up until now, there is no mechanism to identify those strokes that may have a high probability for a large vessel occlusion. It is important to be able to identify those specific patients who have a high probability of a LVO and might benefit from thrombectomy, as we do not just want to transfer all strokes to the thrombectomy-capable centers. So the job for EMS has changed. Where EMS has for many years been conducting stroke screening, we must now also consider the severity of the stroke and determine the probability of a large vessel occlusion, as this will have significant impacts on patient care and destination determination. Most EMS agencies, including Vermont EMS, use the Cincinnati Pre-Hospital Stroke Scale to screen for the presence of a possible stroke. There are several potential tools to assess the severity of a stroke. The most popular severity score used nationally and throughout northern New England is Field Assessment Stroke Triage for Emergency Destination, or FAST-ED. In fact, FAST-ED has been adopted by and is endorsed by the American Heart American Stroke Association. The gold standard stroke severity tool is the NIH Stroke Scale. However, as you can see from this picture, it's way too complicated for use in the pre-hospital or emergency department setting, asking multiple detailed questions and calculating a score from 0 to 42. I generally do not like to do any math when caring for a critically ill patient, and I definitely don't want to calculate a number that involves more than I can count on my 10 fingers. FAST-ED is a much easier stroke severity score to use. It stands for Field Assessment Stroke Triage for Emergency Destination, but it also stands for all the elements of the stroke severity score: face, arm, speech, time, eye deviation, and denial or neglect. Like the NIH score, FAST-ED is scored 0, 1, or 2 for each element. All the elements of FAST-ED are given a score which can total from 0 to 9. Patients with a FAST-ED score of 0 to 1 have a less than 15% probability of having a large vessel occlusion stroke. Patients with a score of 2 to 3 have a 30% probability of having a large vessel occlusion stroke. And patients with a FAST-ED score of 4 to 9 have a 60 to 80% probability of having a large vessel occlusion stroke. Note, any FAST-ED score greater than or equal to 4 is considered critical with high probability of an LVO stroke. Management of the pre-hospital stroke patient with a possible LVO is all about getting the right patient to the right place at the right time. In Vermont EMS, there are only stroke centers capable of performing thrombectomy at UVM, Dartmouth, Albany, and Bay State medical centers. However, the decision on the most appropriate destination for transport is complicated. Patients within the 4.5-hour TPA window should be transported directly to the closest TPA-capable facility. All emergency departments in Vermont are capable of administering TPA. Patients outside of this window, however, if feasible, and within 60 minutes transport time by ground or air, should be transported directly to a thrombectomy-capable stroke center. If the transport time exceeds 60 minutes, patients should first go to the closest ED and then be urgently transferred to a stroke center. Let's now review the updated 2020 Vermont EMS stroke protocol step by step. In order to provide the best possible patient care across our region, we have worked together with Maine and New Hampshire to produce the Northern New England Unified Guideline for Stroke, so that Vermont, Maine, and New Hampshire are all following the same pre-hospital stroke protocol with minimal variation based on local plans. The protocol starts by first determining if you suspect your patient might be having a stroke. Suspect a stroke when your patient presents with any of the following new or sudden symptoms or complaints: unilateral motor weakness, numbness, severe dizziness or vertigo, acute visual disturbance, difficulty with balance or gait disturbance, difficulty with speech, both understanding or producing words, severe headache for no good reason, or altered mental status. Patients with any of these signs or symptoms of stroke should be entered into this protocol and receive appropriate stroke screening exam. If the patient has any signs and symptoms concerning for a possible stroke, complete the pre-hospital stroke screening tool, also known as the Cincinnati Stroke Scale. If the pre-hospital stroke screen is positive, then complete the stroke severity score, FAST-ED, to determine the probability of a large vessel occlusion stroke. Establish stroke alert criteria and notify the receiving hospital of a stroke alert with the findings from the screening tools, thrombolytic checklist, and time last known well. The first step is to perform a stroke screening exam using the Cincinnati Stroke Scale we've been using for years. This assesses facial droop, arm drift, and speech. Remember to check glucose to be sure the patient is not hypoglycemic. If the stroke screen is negative, stop. The patient is unlikely to be having a stroke. Continue treatment with another appropriate EMS protocol. If the stroke screening exam is positive, then proceed with the stroke severity score using FAST-ED. The first three steps of FAST-ED follow the standard Cincinnati stroke screening exam: face, arm, and speech. Note that instead of asking the question, "You can't teach an old dog new tricks," looking for slurred speech, you are asking the patient to name 3 common objects, to assess receptive aphasia, and to show you 2 fingers to assess expressive aphasia. Remember, slurred speech alone is not scored on FAST-ED. The exam then asks about time last known well and adds the 2 questions about gaze deviation and denial or neglect that are strongly correlated with a large vessel occlusion stroke. Eye deviation checks to see if the patient has a normal exam, a gaze preference, or a forced deviation. Denial or neglect asks questions about the patient's ability to recognize their weakness and body parts. The next step is to establish stroke alert criteria. Blood glucose must be 60 or above, as hypoglycemia can cause stroke-like symptoms. It is also important to rule out other stroke mimics, such as a deficit due to obvious head injury or other identifiable causes such as seizure or intoxication. Stroke alert criteria are met if the pre-hospital stroke screen is positive and the time last known well is less than 4.5 hours, or if the pre-hospital stroke screen is positive and the FAST-ED score is greater than or equal to 4 and the time last known well is greater than 4.5 hours but less than 24 hours. If the stroke alert is positive, complete destination determination guidance in the next step of this protocol. Destination determination is a critical part of the protocol. The goal is to get the right patient to the right place at the right time. Patients with FAST-ED scores less than 4 are unlikely to be having a large vessel occlusion stroke and should be transported to the closest emergency department. If the patient has a FAST-ED score greater than or equal to 4, there is a high probability that they are having a large vessel occlusion stroke. For patients with a FAST-ED score greater than or equal to 4, if the time last known well is less than 4.5 hours, the patient is within the 4.5-hour TPA window and should be transported to the closest emergency department so that TPA could potentially be administered. If the time last known well is greater than 24 hours, the patient is outside both the TPA and the thrombectomy treatment window and should also be transported to the closest emergency department. Importantly, patients with a FAST-ED score greater than or equal to 4 and a time last known well greater than 4.5 hours but less than 24 hours are within the thrombectomy window and should be transported directly to the thrombectomy-capable center if the total transport time by ground or air is within 60 minutes. If transport time exceeds 60 minutes, transport to the closest emergency department where urgent transfer can then be arranged. These patients may have significantly improved outcomes and benefit from an emergency endovascular thrombectomy. If there is ever a question about destination determination, contact medical direction for guidance. One additional step is to complete the thrombolytic checklist and document any anticoagulant medications the patient is taking. So now, using this new protocol, when we identify the receiving hospital of a stroke, we report three things: stroke alert, time last known well, and FAST-ED score. FAST-ED can be scored on the paper flow sheet. However, another option that is very helpful for both the exam and destination determination is to use the free phone application, Join Triage. The app can be downloaded from the iPhone or Android platform and is free for EMS. The app walks the EMS practitioner through a series of questions that comprise the FAST-ED exam. Taking a closer look, FAST-ED will ask questions such as, does the patient have facial weakness? Or, does the patient have gaze preference or forced deviation to either side? The FAST-ED app will then calculate a final score and via a built-in decision algorithm that makes over 50 decisions, recommend transport to the most appropriate destination facility. It factors in things like your GPS location, whether the patient is inside or outside of the 4.5-hour TPA window, and if the patient should go to the closest ED or be diverted to a thrombectomy-capable stroke center. A patient inside the 4.5-hour TPA window will be referred to the closest ED to get TPA. A patient outside the 4.5-hour TPA window, for example at 8 hours from time last known well, and with a high probability score greater than or equal to 4, would be diverted to a stroke center unless the drive was more than 60 minutes, in which case the patient would still go to the closest ED and then be emergently transferred. The app does not factor in the option of air transport, so you would have to factor this into your decision-making process. In this example, the patient has a FAST-ED score of 6, which correlates with the large vessel occlusion probability of 60 to 80%, and it is recommended that the patient be transported directly to the closest thrombectomy-capable stroke center. When you press List the closest centers, the app will give you driving directions and times. All of these functions are available on all versions of the app. One other function is available only if your hospital also utilizes the app. The Join button on the app will appear red or gray. If the Join button is gray, it is inactive and you cannot use it. If the Join button is red, then it is active, and by pressing it, you can send your stroke severity score directly to your hospital ED and stroke team. After you calculate the FAST-ED score, press the Join button. When you press the Join symbol, your FAST-ED score will be sent to the receiving hospital, the ED, and the stroke team. It is still important to document the FAST-ED score as usual in Siren and to contact the receiving hospital as per your standard protocol to report stroke alert, time last known well, and FAST-ED score. Here is a short video to watch that shows FAST-ED in action. Whether you are using the paper scoring algorithm or the app, this video will be helpful in showing you the basic steps of performing a FAST-ED exam.
FAST-ED scale training video. We recommend to download the FAST-ED Triage app from the App Store prior to initiating this training. The FAST-ED assessment requires a combination of a few questions and a brief physical examination. Our goal is to train first responders to assess acute stroke patients in the field with the FAST-ED scale and determine the level of care needed in each situation. After the assessment of the stroke severity, the closest and most appropriate level of care, a primary or comprehensive stroke center can be activated to continue the acute stroke code. After opening the FAST-ED app, press Start to initiate the triage. The initial questions involve anticoagulation, the patient's age, and the time the patient was last seen well. The physical exam starts by observing and subsequently asking the patient to smile. Watch for any asymmetry of the mouth at rest and during smiling. The second step of the exam is to ask the patient to raise both arms with the palms pointing up and hold for 10 seconds. It is helpful for the operator to verbally count down from 10. Observe for any downward arm drift prior to the end of the 10 seconds, and score your findings in the FastED app. To check speech, ask the patient to name 3 familiar objects. Slurred speech does not score any points in this category. Score your findings in the FastED app. Ask the patient to show you 2 fingers. Observe and score in the app if the patient understands and follows the commands. The patient is asked to follow your finger as you move across the patient's line of sight. Sometimes it is useful to ask the patient to follow your face. In a gaze preference, the patient is able to follow the finger, but with difficulty. In forced deviation, the patient's eyes are deviated to one side and do not move to the other side. There are 2 extra questions regarding the patient's self-recognition of any degree of weakness and the recognition of the patient's own left arm. After the exam, the app will automatically calculate the FastED score and recommend a level of care based on the severity of the acute stroke.
This next video demonstrates the use of the FastED app. Remember, even if your hospital is not using the app, you can download and use the app for free as EMS to help you calculate the FastED score and be advised of a destination determination. All of Vermont and surrounding area emergency departments and stroke centers are in the app database. Here's an example of a video showing use of FastED on the pad. So you'd start, they ask about blood thinners, say no, they'll ask about the age, they'll enter the time in military manner. Does the patient have facial weakness? Say it's abnormal, arm weakness, mild. Content of speech, name 3 items, abnormal. Show me 2 fingers, say it was normal. Gaze deviation, let's say this patient has a preference. Are you weak anywhere? Abnormal. Whose arm is this? Abnormal. Calculates a score of 6. You hit list the closest centers and it will tell you where to take the patient. You touch the join symbol and it creates your report, and then notice, just like a text message, you have to hit send. And boom, everybody gets your report. You can also then copy this report into your Siren run sheet. By allowing EMS to identify stroke patients who have a high probability of large vessel occlusion stroke and triage them to the most appropriate destination facility, we can save costs, conserve resources, and most importantly, improve patient care and outcomes. This concludes the 2020 Vermont EMS Statewide Protocol Update Module, Stroke and FastED, Part 2.